Good morning to everyone. Now we're going to have one session in English, a different session, with some of our colleagues from neighbor countries. And I would like to thank all of them for accepting our invitation. We have scheduled to have them in person here, but unfortunately that was not feasible this time, but they have promised that next time they will come in Larissa, and I hope they'll keep the promise. Now, why this round table? Because I think we are all facing same problems. And let me say from the perspective of global FFN, first of all, that we do not care about the level of the English. The only thing we care is the level of the patient's care. And we value every opinion and every solution from wherever it comes. So I'm delighted today that we have these distinguished colleagues from the neighbor countries to learn from their experience, how they identify in their countries the gaps and how they find the solutions. Sometimes we think that we are the only ones facing problems, and this is not true. All over the world there are problems, and the important thing is to spend the most of the time finding solutions and not magnifying the problems. With me is going to be today Professor Drousos, who is the current president of FFN Greece. And you will have the opportunity to cooperate with him in the next year and moreover. And without any other introduction, I will ask first Artan Bano from Albania. He's the president of FFN Albania, an orthopedic surgeon. He had some of his training here in Greece, and also he had some training in UK in the University of Nottingham. His main interest in orthopedics is spinal surgery, and I'm delighted to hear his opinion, the obstacles, the challenges he have, and the solutions he had find. Artan, welcome.
Good morning to everyone, and hello from Tirana. I would like first to thank you, Professor Drousos, for the invitation, and then a special thank to Professor Panagiotopoulos for all the support provided all the time since we started to move in this direction. It's very important for me today because, as Professor Panagiotopoulos said, I have finished all my residency in Greece, and I'm very happy being part of this Congress. I would like to share a few slides. Sorry, it will take a second.
Would you like me to help you?
Yeah, just
go on the search screen, the green button.
I working main hospital in Tirana, which is orthopedic, which is in trauma hospital. The last 3 years, I used to work in this hospital, and as we know, the fragility fractures are an epidemic problem, and it takes a lot of effort from the daily job of an orthopedic to treat them. In Albania, there are around 3 million people, and there is only one national trauma center in which I'm working for a moment. But there are other regional and private hospitals which are treating fragility fractures, but not on all these hospitals. There are facilities like a traction bed or other facilities that we need to treat in a proper way patients with fragility fracture. In our institution, we are treating around 1,000 hip fractures per year. And for a moment, we don't have data about the vertebral compression fractures. Most of them are treated in a conservative manner, and a very little number of patients are treated with vertebral or kyphoplasty because of the lack of equipment or high implant costs. I believe that sorry, the patients are and we are in a kind of war of for independence. I mean, patients need their independence, and we are helping to give them this independence after a fragility fracture. I mean, we are, as a surgeons, we are trying to do a good surgery to give them a good construct, but I have the impression that all we know that it's not enough. I mean, there are many points. It's like a chain that we need to take care. And what I feel is that to get in the patient in surgery in our institution, we need to walk more than 10 kilometers. I mean, we need to prepare him to get him fit for surgery, and this is not easy going. So that's why it's a real challenge, because all these patients are, most of them are elderly. They have a frailty, a lot of comorbidities, and problems with anesthesia. Sometimes we have problems getting the patient in surgery because we need to have an ICU bed, and sometimes we have facing lack of ICU beds. But problems are technical problems related to lack of implants or technical support. So all the times these patients have been treated mostly with some kind of fixation like DHS or hemiarthroplasty. But in the recent years, we are using an intramedullary nailing with better results, but still remain an obstacle because we don't have all the time, I mean, implants in order to provide to these patients a quick and good surgery. From a psychological point of view, some of the patients, they do not want to come in the hospital, or others, they don't want surgery. So these are obstacles and we are facing in our institution. There are other problems related to rehabilitation. I mean, in the hospital, we are starting immediately after surgery the rehabilitation of the patients, but we don't have the picture of what's going on at home. Most of them have, they have problems getting in a physio department. And regarding the secondary prevention, our hospital is focused on trauma patient, on trauma, in the treatment of trauma, but surgeons are not so familiar with osteoporosis therapy, and this gap is covered from endocrinologists or rheumatologists in country. And the GP role is very important following these patients in diagnosis or even in therapy of osteoporosis following the hip fracture, wrist or vertebral compression fractures. We don't have geriatricians. We don't have this specialty in Albania, and GP and other physicians are working in order to cover this gap. But seeing all these problems, the last years, as I said, I started to work in this hospital, and together with other colleagues, we thought that we need to do something. And a year ago, we had an contact with Professor Panayotopoulos, which helped us to establish the FFN Albania. It was not easy, actually, because there were a lot of, let's say, problems, but we are very happy that we have established in February of 2022 as a non-profit organization. And now we have started to work in our hospital in order to bring different specialties together. And in the same time, we have a good collaboration with medical societies in the country, with endocrinologists society, with physio rehabilitation, and with nursing society. And we hope to have a good collaboration with neighborhood countries. I believe that education is very important, so we started to think what needs to do first. So we decided to translate the nursing book first, which is translated and printed, and we are working to translate the second book, the Orthogeriatrics. In the meantime, we are planning to do an educational program in hospital. It's not easy when you are working alone, but as a society, I believe that something, and I've seen that something has changed. So with this collaboration, I believe that we think to send the things forward and to have a better patient's care. Thank you for your attention.
Thank you, Artan. You've done an amazing progress during the last 2-3 years, and you show us the surgeon's perspective. But then let's move to Bulgaria and see the geriatrics perspective, how PEPA has started the FFN Bulgaria. Dr. Ferreira is a geriatrician. She spends many years in the UK, in Carlisle. So when she came back to Sofia, she have seen that there was no a very good care for the geriatric patients. So she had adopted a very, I would think, nice and very clever technique to persuade orthopedic surgeons that they can do something better for their patients. So we are eager, Pepa, to hear how you started from your point of view.
Hello from Bulgaria. And I just want to say big thank you for the invitation to participate in the fourth FFN forum in Greece. I apologize, I couldn't be present in person, but I promise next time I'll be there. I can see that there are a lot of problems that we share, and I'm sure we can help each other in many ways. So let me okay. Right. Can you see it?
Yes.
Right. Okay. So what we've done first, we wanted to map the current patient's care in Bulgaria when they sustained a fracture. So when we analyze the results, it shows that acute care is entirely disease-centered care. When the patient sustains a fracture, they go to orthopedic surgery, or in a remote area, they are seen by a general surgeon. So sometimes they really don't get the adequate treatment in the very first place. Another thing that we found was that our elderly patients with fractured knee of femur are often left for conservative management, something that I've just heard is happening in Albania as well. And when we analyzed this trend, we found that initially we thought it's mainly because patients in Bulgaria need to pay for their prostheses, and they are not cheap, definitely. However, we were surprised to find out that the main reason why people refused surgery is their fears and old-fashioned thinking that if you're old and if you get a general anesthetic, you're definitely going to die. Surprisingly, some of our colleagues also weren't very eager to operate on older people for the same old beliefs. So this is something that it's very challenging for us, but easy to work on. Another thing that is happening in Bulgaria, if the patient is admitted to a hospital with fractured knee of femur, the hospital stay is fixed. It's 5 to 7 days. Why is it like that? The payment for the actual treatment is covered by the National Health Insurance Fund, but the fund pays only for the orthopedic input. So it doesn't pay if the patient gets annual because of atrial fibrillation, or if they develop delirium, or if they develop any kind of complication after the surgery, even if it's not directly related to the surgery. I'm not talking about infected wound after an operation. Because of this fixed hospital stay, hospital departments, orthopedic departments, are not eager to extend the length of stay if the patient is not well. So the patient gets discharged home regardless of their level of recovery post-surgery. It's true, they have 2 follow-up appointments that they can attend. I mean, the patients after hospital discharge can attend the department for outpatient consultation 2 times within a month following the discharge. However, it happens very rarely. First, because patients are not well. Secondly, they don't see a point to do it because they've been told we've done our work, the fracture is fixed, and that's it. And the third thing, and the last thing that we found in acute care is that not in all orthopedic departments, in-hospital rehabilitation is available. So we found a great difference in the level of care amongst the orthopedic departments. In Bulgaria, we have 48 orthopedic departments that deal with fragility fractures. Bear in mind that in our study, we haven't included general surgery wards that also can have this type of patient. So it's something different. But nevertheless, as you can see, the acute care is good from the orthopedic point of view. They do it very well. The outcome is not that great for the patients, but it's not because our orthopedic surgeons are not great. The second thing is the rehabilitation post-discharge. So this type of rehabilitation is not paid by the National Health Insurance Fund. So if the patients want, they can pay privately. There are a lot of physiotherapists, so it's widely available if they can afford, if the patients can afford this type of rehabilitation. However, we know that for older people, physical rehabilitation is incredibly important, but cognitive rehabilitation, psychological help is as important as the physical rehabilitation. And honestly, the knowledge and awareness of the importance of this support that our older people need is actually very low. Even medical professionals are not aware of the importance of the cognitive and psychological support for older people and their families. The third thing is that in Bulgaria, we don't have secondary prevention programs that are funded by the National Health Insurance Fund. If the patient will get secondary osteoporosis osteoporosis assessment and treatment, or if they're going to get a false assessment, it's entirely up to the GPs in Bulgaria. So this is the quick, short presentation of the mapping that we have done about the patient's journey when they sustained a fragility fracture. And mainly we focused on the fractured neck of femur because it's common. And as you know, it's one of the most debilitating conditions that could occur in older people. And saying all these things, you can see that the patient's experience is not great. Usually patients and their families are left to deal with the consequences on their own without support. Of course, it leads to very little satisfaction from the medical care. And the negative social consequences for the patients and families are great. Usually, members of the family need to take time off work to look after their mothers and fathers. Sometimes they need to pay for nursing care, and probably around half of the patients that have gone on neck of femur surgery have died within a year, unfortunately. So the main reason for all these problems is that the medical model of care that is driven by National Health Insurance Fund is disease-centered model. So they pay for treatment of a certain disease and not taking into consideration the other problems that the patients may have. Also, we have a very fragmented care, which specialty by itself. So yes, it's a broken bone, that's an orthopedic problem. Or the patient has atrial fibrillation after anesthetic, that's somebody else's problem. Very little communication or no communication between different medical professionals is another challenge that is in front of us as an organization. FFN Bulgaria is a young organization. We've been established at the beginning of this year. So we are young, as I said, we are a young organization. However, we are offering a different model of care, and it does require a large effort to drive the changes in the system. So what we are doing at the moment is we are raising awareness, and we want to make people conscious about the problems in older people, especially those that sustain fragility fractures. We want to make a lot of people aware, not only medical professionals, but also patients, their relatives, society as whole, because we do need this wider support. As you know, the best model of care that exists at the moment for fragility fractures is orthogeriatric model of care. This model of care does not exist in Bulgaria yet. But I hope that in the next few years, we'll have a well-established orthogeriatric acute care. At the moment, we are working closely with two orthopedic departments. One department is in the second biggest city in Bulgaria, Plovdiv. The other department is in a remote area, in the mountain. It's in the hospital in Smolen. So this is important to have a look at the differences that exist when the patient lives in a big city and when the patient lives in a remote area. We started to identify some of the differences. Also, another challenge that we are facing is to make sure that there is an adequate follow-up and continuity of care. So we need to bring GPs on board as well to follow up these patients and to make the patient journey smoother through the different stages of care. We need physical and cognitive rehabilitation, as well as to establish good secondary prevention programs. At the moment, we are focusing on promoting FFN Bulgaria at different forums, and of course, gathering wider support amongst clinicians, patients, and health managers. By the way, having health managers on board is incredibly important, because when we start talking about cost effectiveness and orthogeriatric care is cost effective, then health managers start listening, and it's important to have them on board as well. And what we've done so far, we have started our website. There are a few leaflets available to help patients and their relatives. There are contact details if there are if there are questions. And also we have presented our newly formed organization, newly established organizations into 2 different medical forums. Thank you very much.
Thank you very much, Pepa, for an excellent presentation of the geriatric perspective. Thank you very much. And now I will ask Jordana Devreski from Serbia to share with us her experience. Jordana has been introduced to us by Professor Mikhail a few years ago, and I must acknowledge that in every meeting we have in regional or global level, Jordana is there. So we are happy today to see you participating in our Congress, accepting our invitation, and tell us a little bit your perspective from the rehabilitation point of view. What are you doing in Serbia, and what your problems?
Thank you. Is it everything okay? Do you hear me?
Yes.
Okay. I will. Thank you for a nice word which you sent to me, and I wish you all the best from Novi Sad. I'm so sorry for my absence, but I promise you I will come for next meeting. And I think when we are sitting in one room together, we will, have a new experience. But in this moment, this way is perfect for all of us. And thank you again for your kindly invitation, and thanks a lot for Professor Xanthi also. So I would like to describe something and just to give some information about how is in Serbia. Whoops. Is it now okay? Do you see my,
yes.
My presentation?
Yes.
Okay. We are almost the neighbors, but in 2011, we just have a census in Serbia, and we are just 7 and more than 7,200 citizens, but the density of population is not too much. It's about 92.8 inhabitants per square kilometers. The estimation population of the Republic in Serbia in 2018 is approximately very close to 7 millions. I don't know how it is now, but I think it's very close to 6.8 millions. In our country, we got in 2018 a lot of health institutions, and some of them is still working, some of them is till COVID closed, but for income patients, we got in primary health care 21 centers, general hospitals 40, special hospitals 34, institutes, clinics and clinical centers 4, like we have in Belgrade, in Novi Sad, in Kragujevac and Niš, and some clinical centers also 4. In all of these health institutions, we got a rehab department. Some of them got whole units, different units. In the clinical centers, we got a department, the clinics. It just depends how big the city is. For example, in Novi Sad, where I'm still working, it's a clinical university hospital, clinical center. There is a department with 120 income beds, and every day a few doctors are working for outcome patients. So that's the way how we treat our patients. Also, we got the patients with fractures, fragilities. But generally, in our country, we got the rule book, and what that means, that's the book which include all types of indication, what is necessary to do, how long is duration of treatment, minor and conditions of exercises, the right to medical rehabilitation. So the rules is, let's say, for all doctors who are specialists in physical med and rehab, the same. But it depends of equipments what we have in that area, in that region of the country. All indications for our patients with fragility fractures are same, but some of them got the prolonged or need prolonged rehabilitation, or got all the treatment which start in orthopedic department, and then for 24 hours when the patient are in orthopedic department, they got the rehab, then start early rehab treatment, and it's still existing during when the patient is on orthopedic department, and sometimes when the patient is going directly to the rehab department, they are in continual way. Sometimes we are showing the exercises what the patient can work at home or going to the spa. So we have a prolonged period of rehab, or it means how is on which moment the operation, the orthopedic done the operation, or how they treat it. But it's almost the same in all cities. It depends in which region is the fracture, and that's the indication from for prolonged treatment. Because, for example, if the patient is living here in Novi Sad, then patients are going for a spa treatment very close to that region. It's very useful, then the family can come to the spa to visit for a weekend, or to take patient from spa home. And we got 13 spas which are including on the list for prolonged treatment in rehab. And all kind of physical medicine we got, but the goals of the rehab for all of our patients with fragility are the same: just to prevent edema, to prevent complication, stimulate callus formation, establish full function, independence of quality of life, and prevention of new falls and fractures. All patients what we got the same goals, but sometimes the goals are not 100% recovered, so we do the best. The distinguish is in two phases of rehab. The first phase is of mobilization, and the second is of post-immobilization. It's just the special plan which we made for all of these patients. In our hospital, in my hospital, we are just making the individual plan for these patients. But generally, we are very friendly, and we like to prescribe kinesiotherapy, electrotherapy, thermotherapy, magneto, laser, hydrotherapy, drug therapy, everything what is necessary when we make an individual plan. Kinesiotherapy is the queen of our equipment and of our treatment. Patient is not familiar with kinesiotherapy, but for a few days they know that is the best solution for going out of the bed and take and be in good conditions, and for next period, in a short period, be the best recovered for our patient. But nobody, patient is not that user-friendly with kinesiotherapy and with exercises, especially when they are geriatric and they don't like to do exercises every day, for example, two times per day. The key to the success of rehabilitation is early start of treatment. We start on a orthopedic department. Motivation of patients, it's terrible. It's terrible to motivate all patients. Sometimes we do the best, sometimes it's not good, but we're trying to do the best and to find the best sentence, what and how we can motivate our patients to early mobilization and to just to do the best for walking and to going home with good results, with full functional range of movements and so on, what we are measuring. And continuing treatment after recovery, and of course, early prevention. We are still talking about prevention. We are working on that, but I think we don't have a really good results, and we must be very, very passionate and very, take a lecture or something just to prevent with the general practitioner, just to do something which can prevent the falls. And let's say the treatment of complication with adequate choice of kinesiotherapy for again, and some other physical procedures. The patient said, this is very good when I take some laser therapy, magnetotherapy, hydrotherapy, but exercises, I'm not feeling good, I'm not friendly. But generally, in kinesiotherapy and all procedures of physical therapy is in a short time giving best results and good quality of life for our patients. Generally, I think when we are working like a team with orthopedic doctors, with the geriatrician, internal doctors, other physicians, GP, nurses, some with the family, and basically and mainly with our patients, we will get good results. If one of the members of the team is not good and not giving all the best, our results will not be on a good level. It can be better. And I think in next period, we must do the good connections with all members of the team. And of course, describe to our patients again what is the best for them when they got the fractures and how they can be heal and recover for full range of movements and good quality of life. I know it's terribly, I know it needs a lot of time to describe because there are many different kind of people with different level of knowledge. So it's very difficult, but I know the doctors generally got a good motivation to give all the best which they know for our patients. And if we are working like a team and giving all the best, we will get good results, and we will have a good results of rehab all around, basically all around in this region where we belong, because we got almost the same problems in Greece, in Albania, in Bulgaria, in Serbia, and other countries in the region. So I think we will be in touch and we will change the information, and for next meeting we will get a new results and better results than now we got. Thanks a lot.
Thank you very much, Jordana. Very nice presentation of what rehabilitation medicine can do about patients suffering from a fracture. And now we'll move to Olena. from Ukraine. She's also rehabilitation physician, and she's the president of National FFN of Ukraine. And she's going to give us her perspective on rehabilitation, the effort they've done in Ukraine, even in difficult situations. And the floor is yours, Olena. Thank you very much for participating.
Thank you, Professor, for your invitation. Thank you all for your attention. And I'm happy to be part of this event. I am a physician of physical and rehabilitation medicine from Ukraine. And now we have change in system delivering rehabilitation service in Ukraine and other service. And my presentation will be about the role of physical exercise in rehabilitation person with fragility fractures and sarcopenia. And second part of my presentation will be about situation in Ukraine now with management of fragility fractures. About 500,000 fragility fractures occur annually. 20-25% of the hip fragility fractures lead to fatal consequences. And after the primary fragility fractures, next is the risk of next fragility fractures is very increased. And this condition will be connected with other conditions, for example, sarcopenia, sarcoosteopenia, and sarcopenia of obesity. And all these conditions increase risk of other pathological condition and decrease survival of this patient and quality of life. Fragility and sarcopenia are common age-related conditions associated with increased adverse outcomes such as falls, mobility disorders, the need for long-term care, and this. Sarcopenia is generalized skeletal muscles disorder characterized by reduced skeletal muscle strength and mass and associated with a range of adverse health outcomes, high social and economic cost. This condition is a clinical biomarker to identify people at increased risk of physical disability, and physical activity has also been identified as a potential prevention strategy to slow the development of both fragility and sarcopenia. Sarcopenia is often associated with osteoporosis and obesity and worsens the prognosis for quality, disability, and future survival. Osteosarcopenia, bone and muscles tissue are in close relationship, and the aging process lead to the loss of the mass and functionality of both tissues. Reported that muscles and bones are regulated by many common genes, endocrine regulation networks, and signaling pathway. Increased risk of fractures in patients with sarcopenia and osteoporosis is associated with decreased muscle mass and stretch, decreasing bone mineral density, and limitation mobility. Fragility fractures management in our country consists from assessment and screening. We use FRAX. FRAX translate to Ukrainian language, and we can use this. Treatment consists from surgical and pharmacological treatment. Surgical treatment in the traumatological department, high specialized clinic, and pharmacological treatment start in surgical department, but continued with family physician or in rheumatological department. It's mean from health condition of a patient. Prevention, primary and secondary, and rehabilitation. Today I'm tell about rehabilitation more. We have 3 rehabilitation period, acute that start in surgical department usually, and post-acute period and long-term period. Acute period in surgical inpatient department starts. A rehabilitation team start the rehabilitation intervention in this department, but continued in rehabilitation department when patient can have more intensively rehabilitation, and it's safe for a patient. I work in rehabilitation inpatient department, but we have outpatient department too, and some part of rehabilitation care is in long-term period. It's maybe in rehabilitation department, outpatient, or at home, or it maybe community-based rehabilitation. We have a rehabilitation center that it's no include in health care system. Rehabilitation team for patients with fragility fractures usually consists from PRM physician, physical therapist, or assistants of physical therapist, occupational therapist, and them assistants. Rehabilitation nurse and psychologist. This team consists creating the individual rehabilitation plan and program of therapy or specialist including in this individual rehabilitation plan. Now I work in working group in the Ministry of Health of Ukraine for creating electronic a part of rehabilitation to including this part in electronic health system of Ukraine, because now we documented process of rehabilitation only on the paper. Work of rehabilitation team in Ukraine based on biopsychological model, functioning disability and health with using international classification of functioning disability and health, and on interprofessional rehabilitation and person-centered approach. We work on based rehabilitation cycle. It's a strategy based on ICF, and this cycle consists from 4 stages. It's assessment, assessment functioning, computer tomography scanning, managing resonance imaging, dual X-ray absorptiometry, wrist dynamometry, walking speed, up and go test, and other tools as need. It's depends of needs of rehabilitation needs of patient and problem with functioning. A segment, it's next stage. On this stage, we setting the goals, consist the rehabilitation team and create rehabilitation plan. Choose the rehabilitation intervention, and on next stage we realize our rehabilitation plan, and on next stage evaluation we repeat assessment and for understand the effectiveness of rehabilitation. For functioning assessment, patient with fragility fractures, we can use different core sets of ICF. It may be rehabilitation sets, minimal sets of environmental factors, ICF generic 7 sets. It may be musculoskeletal acute and post-acute sets, osteoporosis sets, geriatric sets, and obesity sets. For management of falls, we use recommendation American Physical Therapy Association usually assessment risk of falls provide physical therapist, and he need understand experience fallen in previous 12 months, or has patient difficulty with balance or walking. If yes, conduct balance and mobility screening. If patient have problem with balance and mobility, we start conduct multifactorial fall risk assessment, including medication review, medical history, and assessment of strength, balance, mobility, gait, activity, daily living, footwear, environmental hazard, cognition, neurological function, cardiac function, and vision. If risk stay, we create a program for this individual rehabilitation plan for this patient that will be include strength training, balance training, gait training, environmental adaptation, footwear correction, recommendation for foot impairments, education patient, and family if it's need, or caregivers that help the patient, and exercise. Resistant exercise is current recommendation as a first-line treatment for sarcopenia. We use resistant training for this patient. It can involve the use resistant machine, free weight, body weight, exercise resistance bands, and improve muscle strength, mass, physical performance. Older adults with sarcopenia also can have increased risk for falls and reduced cardiorespiratory fitness. The exercise program for this individual involve a combination of exercise models, resistant exercise, balance exercise, exercise for flexibility, and aerobic training. This training is very effective for this patient, and exercise intervention can improve sarcopenia biomarkers in this patient. Exercise training aimed at improving physical ability or skills as an acute response to training, and chronic training adaptation is driven by training stimulus. The exercise prescribed during rehabilitation must be specifically targeted to induce improvements in the desired outcomes. Rating of perceived exertion can be the useful method for choosing the intensity of exercise. The main principle of exercise training is specificity, overload, and progression. And for this exercise training, create the program of exercise training, we use principle of fit. This is frequency, intensity, type of exercise, and time duration of training. Exercise might be individualized to induce the desired adaptive response in each person. Different persons have different in program of physical therapy and exercise training too, because they have different tolerance to exercise, and different comorbidity, and this patient have other rehabilitation needs, so program not only concentrate on attention only fragility, fractures, and risk of fall. Now we have many barriers for provide rehabilitation care and help patient with fragility fractures, and we have Moses patient in this time. The Russian army completely destroyed 40 and damaged 500 hospitals. In eastern Ukraine, the healthcare system is almost completely destroyed. The number of institutions providing care for people with fragility fractures, including rehabilitation, has significantly decreased, and medical specialists are not in safe. Many people are afraid to visit medical facilities due to constant missile strikes. About 14 missiles are dropped on Ukraine per day. This is really hot for now situation in Ukraine. There has been a shift in focus of care on injuries, wounds, and burns and fractures. This means a lower priority in the care of patients with non-communicable diseases and continue of its provision. For example, patient with osteoporosis and patient with fragility fractures due to occupation, the territory, destruction and meaning the road, there were problem with logistic of delivery of medicines, medical supplies and aids. The Russian military continue to block humanitarian convoys, preventing them from delivery medicine and evacuate people in need. Many older people have fractures when they hide from shelling or try to evacuate of their own. The number of people with fragility fractures has increased, and most of them are unable to evacuate on their own from fighting sites. They are isolated in their homes or shelters and have difficulty accessing to medical care and water, eat, and other. According to United Nations, more than 10 million people have been displaced. About 1.5 million have become internally displaced, and another 4 million have left Ukraine. This has led to increase in burden on the healthcare system in some West Ukraine. Of Ukraine, some healthcare workers, doctor, pharmacist, rehabilitation specialist left Ukraine. Only about half of pharmacies are open now. In areas where there is no fighting, medical and rehabilitation assistance is provided, but there are system overloads and resistant to the access to some service. Today, it is impossible to say exactly how catastrophic the consequences of war will be for population of Ukraine, especially persons with fragility fractures. And now for evacuate patient and patient with fragility fractures too, and patient aging patient, we use training mini hospital for evacuation from areas of hostilities of person in need to future specialized treatment. However, Ukrainian healthcare system is gradually adapting to the challenges that have arisen. We have the support of volunteers in Ukraine and abroad, governments and international organizations, including the World Health Organization, United Nations, European Union. Our doctors and rehabilitation specialists are gaining new knowledge and skills to work in conflict situation, and many organizations go to Ukraine for educate our specialists, and now we have many training online and offline, and many medical specialists from other country go to Ukraine for help us with our patients. Every Ukrainian is doing everything to bright victory cause by fighting on his own fronts. Thank you, colleague, for attention and for support.
Thank you very much, Alina. Very nice presentation for the problems you are facing before and now. And now Professor Drossos had prepared many questions, but since we are a little bit behind time, he had promised me that he's going to call you here in Alexandroupolis to be discussed in person in another occasion. So I will think that he's going to keep his promise. George?
Well, we thank you all for your participation in our fourth Congress of the Greek FFN, and we hope that we'll meet soon in person, since we are in a better condition concerning the COVID situation. We thank you all.
Thank you very much. Thank you.
Thank you.
Thank you.
Thank you. Thank you. Have a nice time. And see you
Thank
next
you.
week.
Thank you very much.
Thank you.
See you soon.
Thank you.
Bye.